I am Hi, I'm Dr. Rajiv. Let's study about respiratory system. So in respiratory system, basically our focus will be based on pharmacology, covering most of the physiology. Let's see. So we'll discuss one disease, right? So asthma, type 1 hypersensitivity reaction. It is basically a type 1 hypersensitivity reaction. It is precipitated by the allergy also, right? There is increase in the inflammation process. It is reversible in nature. Whereas COPD is irreversible in nature. Okay, there is bronchoconstriction, and the treatment is nothing but the bronchodilators and the anti-inflammatory drugs. So bronchodilators, we have beta-2 agonist, anti-muscarinic, theophylline, magnesium sulfate, very important. Okay, omalizumab is the anti-inflammatory mast cell stabilizer, 5-LOX inhibitor like xylitol. Okay, now this xylitol is banned because of being hepatotoxic in nature also, and like we are using corticosteroids is the most common, and leukotriene receptor antagonist. Okay, it blocks the CYSLT1, that is all the Lucas, Montelukast, Jaffe Lucas. Okay, so this is very important, the classification of the how it is acting on asthma, right? So approved monoclonal antibody for asthma is omalizumab, that is IgE against the IgE, that is the allergic immunoglobulin. Mepolizumab, rocilizumab, okay, these are IL-5 acting against the IL-5. They are also used in with asthma. They are used in Churg-Strauss syndrome, and it recruits the eosinophil. They are recruiting the eosinophil, so there will be increase in the eosinophil concentration using this monoclonal antibody. There is benralizumab, that is the anti-IL-5 receptor, that is CD125 against this monoclonal antibody. It targets the alpha chain of this receptor. Then there is caliximab, okay, it's against the CD4. Ligelizumab, that is IgG epsilon chain C against, right? Okay, so these are very typical terms. These are not used so regularly in our daily practice, but definitely within 5 years, 5 to 10 years, they are going to be in the market with a low price, and you are going to use it. Okay, so you are the future, you should know about this. Lebrikizumab, that is IL-13 antagonist, and rukizumab, that is IL-13 antagonist. So these you can understand, like these receptors as well as these immunoglobulins and interleukins are associated with asthma. So that is very, very important for you to understand. Gomiliximab and lobiliximab, this is against the CD23. It was asked in recent examinations. So these are all MCQs. These are all basically MCQs which will be asked in the like PG exams, right? Dupilumab, it is IL-4 receptor, and it is a new drug, and most of the monoclonal antibodies are new drugs, so you should know about it, right? So the management basically focus on the two things, that is acute attack asthma, how to manage it, and the second is the prophylaxis of the asthma. Okay, so first we'll discuss about acute attack of asthma. There is the drug is the SABA, that is the short-acting beta-agonist, short-acting beta-2 agonist. So the lungs has the beta-2 receptor, okay, and the heart has beta-1. So beta-2 agonist will be present in the short-acting beta-agonist, and these all are like salbutamol, right? This is short-acting. The long-acting is the for the maintenance and the prevention of asthma. Okay, like salmeterol, formoterol, something like that, right? Now prophylaxis has we use the anti-inflammatory drugs we have seen. So in the episodic context, that is seasonal or even exercise induced, we have drug of choice is the inhalational corticosteroids. Okay, more than used for mast cell stabilizer. They both are used, but inhalational corticosteroids are basically used. Now it is very important, like prophylaxis, we use a chronic or persistent term. Now we take the history from the patient, so there we decide it is mild, moderate or severe. So in the mild category, we use inhalational corticosteroids, low dose ठीक है, एंड वी स्टेप अप द थेरेपी, वी डोंट यूज इट एट वंस, ठीक है, धीरे धीरे आगे बढ़ाते हैं, उसका डोज को बढ़ाते हैं, राइट. एंड इन मॉडरेट वी गिव लो डोज ऑफ inhalational corticosteroids as well as LABA. In the severe bronchial asthma, we use inhalational corticosteroids in higher dose with the LABA. Okay, so this is very important, how we treat the chronic asthma or the persistent asthma. This is how we take the history from the patient and we decide it's mild, moderate or severe, and then we use the drugs associated with it. In the acute attack not responsive to short acting beta-2 agonist, it's called status asthmaticus, or acute severe asthma is the new name for this old term status asthmaticus, acute severe asthma. So in the recent books you will see this name, right. No role of the mast cell stabilizer is there in the acute severe asthma, we don't give them. Okay, so acute attack not relieved by usual dose of salbutamol is the acute severe asthma. Treatment is hypoxia. So humidified oxygen we give because there is hypoxia, patient cannot breathe, and sodium bicarbonate to treat the metabolic acidosis because of this hypoxia. Then hydrocortisone 100 mg IV is given. High dose salbutamol is given in the inhaler and the nebulizer form. It is still, if not responsive, we give magnesium sulfate, inhaler or nebulizer. If still not responsive, we give the ipratropium, then the theophylline, and then the aminophylline, and at last we give the halothane. With the mechanical ventilation we go for the general anesthesia. So halothane has bronchodilator property, as well as you should understand this high dose salbutamol will have action on the respiratory effort. Okay, and we give salbutamol IV and terbutaline subcutaneous. You should understand this. Now, severe chronic asthma. The severe chronic asthma is not controlled by the highest dose of inhalational corticosteroids. It's called the refractory asthma. So this is called the refractory asthma. The drug of choice is oral prednisolone, and if not responsive, we give we call it corticosteroid resistant asthma. We call it corticosteroid resistant asthma, where there is the role of monoclonal antibody against the IgE omalizumab. Okay, so this is should be very clear, acute asthma and chronic asthma, right, and how we treat them. Bronchodilators, we have beta-2 agonist. So here you can see beta-2 agonist mechanism of action is beta-2 receptor. It increases the cyclic AMP and causes the bronchodilation. So this is the main action, right, and asthma is reversible, so there will be bronchodilation. In the case of COPD, these drugs will not going to act because it is an irreversible damage to the lungs. Okay, now the drugs which we are going to see is SABA, short acting, long acting, and ultra long acting. Okay, so these are the drugs: salbutamol, albuterol, terbutaline, pyrbuterol, metaprotenerol. Right, this is SABA. LABA we have salmeterol, formoterol, and bamboterol. Ultra LABA is the indacterol, vilanterol, clenbuterol, and oladaterol. Okay, these are ultra long acting. Okay, so there are things we have to understand, like we have to guidelines to follow, and we use SABA plus LABA. Okay, so in prophylaxis and acute attack we use like formoterol. Okay, and it's very important that basically the levo forms are the active form. Okay, this is the pharmacokinetic property. Route is basically inhalational, okay, oral sometimes. Subcutaneous is the terbutaline, and IV is the salmeterol. Okay, side effect of beta-2 agonist is very important. Okay, now this is like you can learn by this mnemonic T3 and H2. Okay, so there are tremors. This is the most common side effect: tachycardia, tolerance, or tachyphylaxis. So this is the side effect of beta-2 agonist. And in H2 we have a side effect of hypokalemia and hyperglycemia. So there is decrease in the potassium and there is increase in the glucose. Now this hypokalemia, decrease in the potassium level, okay, it is also caused by insulin, and these are the potent questions ki how you will treat a patient with hyperkalemia. Okay, so normal potassium is 3.5 to 5.5. If it is more than 5.5, so how we can reduce it? by using insulin or beta-2 agonist. ठीक है, तो most commonly it is a side effect, right? So you should understand that this is very very important, and this is the most common side effect. It's a very good MCQ, and it asked in the Viva also. Okay, now the corticosteroid is nothing but it reduces this tolerance, and it is very commonly used, and the use of corticosteroids via this inhalational route, you should learn about how to use it. Okay, why should we wash our mouth, because of to prevent this oral candidiasis, and there are different color codes of this inhalational device in which different drugs are given with different color codes, so you should know about these things, right? Now, antimuscarinic, it is ipratropium, tiotropium, eumelinidium, and aclidium, and revifenacin. Okay, the route is basically the inhalational one. It add-on therapy to the beta-2 agonist. Okay, it is used basically in the COPD more than in asthma. So they are very nicely used in the COPD patients, right? Drug of choice asthma due to beta blocker. So in case of beta blocker causing asthma, this is the drug of choice. Anti-muscarinic agents are the drug of choice, because beta-2 agonist cannot work because of the use of this beta blocker. If the receptors are already blocked, we cannot use the beta-2 agonist. Okay. Now, asthma during labor or postpartum asthma, okay, there is no role of beta-2 agonist. So here we will use the antimuscarinic agent. The side effect is the decrease in the mucus production. The side effect is the decrease in the mucus production, whereas this beta-2 agonist will increase the mucus production. Beta-2 agonist will increase the mucus production. Also, a side effect is the urinary retention, which is, you will learn that, like how this and muscarinic and parasympathetic activity is there in the urinary bladder. It is the very very important question in pharmacology, as well as you have to understand the concept for your daily practice in your surgery wards. Okay, now theophylline, chai mein rehta hai, coffee mein bhi rehta hai. This theophylline is very important. These are methylxanthines. So what is there, like see, this is theophylline, caffeine, and this is theobromine. So in the tea, theophylline concentration is the highest. Okay, in the coffee, the caffeine concentration is the highest, but theophylline is also present. In the chocolate, theobromine is highest, but there is also theophylline also. Okay, these all are stimulants. These three are stimulants. Theophylline acts peripherally, as well as caffeine will act in the centrally. Okay, this is very important. This caffeine is also used in headaches, migraine headache, and theophylline is used in asthma prophylaxis or apnea of newborn. It is very important. In the pediatrics, you will learn about this apnea of newborn, whereas theophylline is also used over there. Okay, it leads to bronchus dilatation. That's why in the newborn, when the baby is not crying, we are using this theophylline to dilate the bronchus, right? Now, and it also causes contraction of the diaphragm, okay, and stimulates the respiratory center in the brain of the newborn. Okay, so it's used, very important, theophylline. How it acts, it is the mechanism of action will be asked from you. Okay, so the first mechanism is the PD4, okay, PD4 inhibitors or PDE4 inhibitors or PD3 or 5 inhibitors. Okay, this is the phosphodiesterase enzyme 435, right? So it increases the cyclic AMP and it causes the bronchodilation. This is the first mechanism of action. The second mechanism of action is the calcium A3 inhibitors and adenosine inhibitors. These are the three mechanisms how the theophylline is going to act. The new drug that is only PD4 inhibitors are roflumilast, silomilast, ibudilast, okay, and apremilast is also used in psoriasis, but these three are used in bronchial asthma. These three are used in the bronchial asthma. This is for the psoriasis. Don't get confused. This is a potent MCQ. That's why I have written here. Okay. Now the drug are T, that is theophylline, etophylline, aminophyllin. Chai mein पाया जाता है T, so it is theophylline, etophylline, and aminophyllin. Theophylline is given orally, but these two can be given IV also. Okay. Now in the pharmacokinetics, it is a cytochrome P1A2 it get metabolized. And the drug interactions of theophylline is very important. Why? Because it sometimes like it has a mechanism by CYP1A2, so it decreases the effect of these drugs, that is griseofulvin, phenytoin, smoking, so rifampicin, and enzyme inhibitors like omeprazole, cimetidine, allopurinol and erythromycin, it increases the effect of those and decreases the effect of the enzyme inducers. Okay, so you will learn more. Okay, don't get confused. And smoking, you can see it is very important, respiratory problems and smoking. So there you see. Now here theophylline, it has a low therapeutic margin. Okay, so it needs a therapeutic drug monitoring. The range of therapeutic range is 5 to 15 microgram per ml, right? The side effects are diuretic. It is an arrhythmia, causes arrhythmia, causing seizure, nausea, vomiting, pulsatile headache and GIT discomfort. So basically the adenosine inhibitor, it causes these side effects. Okay, so these are mechanism specific side effects. Similarly, PDE inhibitors, it is the side effects caused by the it is caused by the phosphodiesterase enzyme inhibition. Okay. Now the magnesium sulfate, it is a potent short note. The uses and contraindications of magnesium sulfate via different routes of administration. The magnesium sulfates in asthma basically blocks the entry of the calcium. Okay, it is used in the torsade de pointes. It is used as an antacid. Barium toxicity, hypercalcemia, laxatives, it causes the diarrhea. It is used in eclampsia, very very important. It is a tocolytic. Status asthmaticus, it is magnesium sulfate is used, we have seen already. Okay, earliest sign of magnesium toxicity, eclampsia, or when you learn about in gynecology, there you will see there is a loss of deep tendon reflex. Okay, so patellar reflex will be lost. Okay, it is what is the antidote for magnesium toxicity? It is IV calcium gluconate. It is IV calcium gluconate. Now the anti-inflammatory drugs which we are seeing was the omalizumab. Now these omalizumab, these are injectable, not oral, never oral, right? All the monoclonal antibodies are injectable, never oral. It is an IgE inhibitor, 3 inhibitor, IgE inhibitor, sorry, subcutaneous injection 2 to 4 times. Okay, 2 to 4 times injections will be given weekly. Okay, now the mast cell stabilizer, it is the cromolyn sodium or chromoglycate or nidocromel. Okay, so these are given inhalational. Cromolyn, chromoglycate, nidocromel. Okay, the mechanism is it blocks the chloride channel and blocks the C fibers. Okay, uses prophylaxis, exercise induced or the seasonal asthma. So it is used in the mast cell stabilizers are used. But the drug of choice for seasonal asthma, if you will say, it is inhalational corticosteroids. Okay, acute attack, there is no role, we have discussed about this. Antihistaminic and mast cell stabilizer, both action, ketotifen and olapatidine. It is very important because the patient with allergic rhinitis, when come, we can give this kind of this drug, and it is very commonly used these days. Olapatidine. Okay, leukotriene receptor antagonist, it blocks the cysteine LT1 receptor, and these are the examples: montelukast, zafirlukast, pranlukast. The side effect is eosinophilia because it causes this recruitment of the eosinophil, and it is causing this syndrome. There is a Churg-Strauss syndrome. You learn in the medicine more about it. Okay. Now corticosteroids, a broad action is mainly, this is a mast cell stabilizer. It also causes bronchodilator. Okay, via the nitric oxide. The route is basically inhalational. Okay, the 2 to 5 micron particle size will be used, and beclomethasone. Okay, not betamethasone, beclomethasone, fluticasone. Okay, triamcinolone, mometasone, budesonide, cyclisonide, flunisonide. So these are the drugs. These are the drugs, and IV hydrocortisone is used in the status asthmaticus, and oral prednisolone is used in the refractory asthma. ठीक है. Advantage of inhalational over the oral is a safe in pregnancy, no Cushing syndrome, ठीक है. But in high doses it can cause Cushing syndrome, ठीक है. So you will learn Cushing syndrome. These are steroid induced, okay. Moon phases will you see, and many other things. No ACTH suppression in low dose, but yes, high dose there is ACTH suppression, and there will side effect like hoarseness of voice, oral thrust, candida infection. This is an important question, okay. So this is why we wash our mouth, okay, rinse our mouth after using of the inhalational corticosteroids. This we have to tell to our patients also. Prevent use plastic spacer. We do the gargling, okay. No candida seen in the cyclosonide. This is the soft steroid, and very important, we use oral nystatin paint. Esophageal candidiasis, we use oral fluconazole. Now we are going to another topic. Asthma is now done, okay. Now we are going to idiopathic pulmonary artery hypertension, and we'll see some basic it is a very very important question. So we'll see just the important drugs and mechanism. So this is the endothelial cell, and what happens in idiopathic pulmonary hypertension, there is a decrease in the nitric oxide production and increase in the endothelin, okay. So what happens, this vasoreactive drugs which can be used in pulmonary hypertension are the calcium channel blockers, amlodipine and nifedipine. So pulmonary hypertension with hypertension, and vasoactive negative, like we use this like Pepsi. This Pepsi is nothing but PGI2 analogs, endothelin receptor antagonist, PDE5 antagonist, SGC activator, and IPR agonist, and there are many not approved drugs. So let's see what are those, okay, just the drugs name, okay. So the amlodipine, nifedipine and calcium channel blocker we have said in the vasoreactive positive idiopathic pulmonary artery hypertension, and in the Pepsi we are seeing PGI2. So in PGI2 we have TI. So T for trepsonil, iloprost, epoprostinol, okay. So we are giving in drips, and this is the most effective drug in the pulmonary hypertension. In the endothelin receptor antagonist, it is contraindicated in the pregnancy. We use this bosentan. So there are all the tan, right? Sitaxantan, matisentan, ambrisentan, okay. So they are given orally, but they are contraindicated in pregnancy. PD5 inhibitors, sildenafil and tadalafil. So it is drug of choice for impotency with pulmonary hypertension. We give this sildenafil. SGC activator, this is a soluble guanyl cyclase. This is a new drug, riociguat. This IPR agonist, this is also acting on the PGI2 receptor. It is selexipag. And imatinib and nitric oxide inhalational these are also drugs used, but they are not approved by the FDA or DCGI. What are analeptics? Analeptics are nothing but the respiratory stimulants. These are the respiratory stimulants. So you will be used in different respiratory problems caused by a different poisonings or other problems, like doxapram and almitrine. These are used in the barbiturate poisoning and COPD. Flumazenil, it is used in the benzodiazepine poisoning. Flumazenil is the drug of choice. Acetazolamide in the mountain sickness, naloxone in the opioid poisoning. So these are the analeptics or the respiratory stimulants, okay, very important. So the last topic, basically we are going for cough, okay. So cough, we basically use the expectorant and antitussive. The expectorants remove or clears the respiratory mucus, okay, and antitussive suppresses the cough center, okay. So expectorant will be used in the productive or infective cough, and your antitussive will be used in dry or allergic cough, okay. So first we'll go for the productive and infective cough. So we use drugs like mucokinetic and mucolytic. In the mucokinetic we use guanfacine, and mucolytic we use bromhexine or ambroxol, and acetylcysteine. It was used in COVID, very commonly, and carbocysteine and dornase alpha. These four are nothing but the mucolytic, and mucokinetic, the movement of the mucus will be increased by guaifenesin. Okay, so mucolytic liquefies the mucus. Okay, and it is in very cough, in a very congested cough in cystic fibrosis, we use this mucolytic agents. Okay, antitussives we have seen, so it may be opioids or it may be non-opioids. So in opioids we have morphine, not used nowadays. Codeine, yes, we use, but it is also not so commonly used. Dextromethorphan, this is NMDA receptor antagonist. It is most commonly used in our cough syrups, and noscapine is also present. Okay, if we will see opioids versus non-opioids, addiction, constipation, and sedation. This is ACS, and these three are always present in the opioid antitussives, but which are absent in the non-opioid dextromethorphan. Right? Naloxone is used as a morphine or codeine poisoning reversal. So these are basically the respiratory things. Thank you for listening, and we'll meet again with a new chapter in pharmacology. Okay, thanking you.